Welcome to our discussion on the Anaerobic Activity Index, a novel framework for quantifying anti-anaerobic antibiotic exposure and its effects on patient outcomes. The 2026 Surviving Sepsis campaign advises against anaerobic coverage in sepsis without clear risk. Anti-anaerobic antibiotics are linked to ventilator-associated pneumonia, mortality, and acute graft versus host disease. Current classifications are binary and imprecise, lacking a standardized quantitative score for anti-anaerobic exposure. Commensal anaerobes are crucial for colonization resistance, protecting against pathogens like Clostridioides difficile and methicillin-resistant Staphylococcus aureus. Antibiotics disrupting these anaerobes can lead to dysbiosis, with effects that vary between patients and are often irreversible. This disruption may contribute to conditions like ventilator-associated pneumonia and graft versus host disease, highlighting the need for precise measurement of anti-anaerobic exposure. The Anaerobic Activity Index, AAI, was developed through a systematic review of 88 publications. It incorporates susceptibility data from 7 anaerobic bacterial groups. Using supervised binning, scores were minimized for ties and summed to create a composite score for 21 antibiotics, offering a detailed metric of anti-anaerobic potency. Each antibiotic was evaluated across 7 anaerobic bacterial groups, capturing the diversity of anaerobic flora. The analysis included over 540,000 isolate antibiotic pairs, providing a comprehensive assessment of antibiotic effectiveness against anaerobic bacteria. The AAI scores reveal a 15-fold potency range, from aztreonam at 4 to meropenem at 59. High-scoring antibiotics like carbapenems and tigecycline highlight the limitations of binary classification. Notably, linezolid scores 53 but is not considered anti-anaerobic, showcasing the AAI's ability to address classification discrepancies. This study involved 509 adults at UNC J.C. Burns Center from 2016 to 2023, focusing on burn intensive care unit patients with 5 to 80% total body surface area. Exclusions were made for early death or discharge. Amino acid infusion exposure was categorized into quartiles. The primary outcome included bacterial cultures, healthcare-associated infections, and death, adjusted using logistic regression for Bauch score and comorbidities. Patients in the highest aristolochic acid exposure quartile were older, with larger burns and more inhalational injuries. Median age was 55, total body surface area burned 17%, and inhalational injury 31%. These differences highlight the importance of adjusted analyses. Significant p-values: age 0.032, percent total body surface area 0.001, inhalational injury less than 0.001, Bauch score less than 0.001. A dose-response relationship is evident between 7-day average annual income quartile and 90-day adverse outcomes. The highest average annual income quartile has nearly 3 times the odds of adverse outcomes compared to the lowest. Adjusted odds ratios highlight significant differences, especially in mortality rates, even after accounting for burn severity and comorbidities. The AAI excels over binary classification by revealing a dose-response relationship. It accurately scores linezolid's high anti-anaerobic activity previously overlooked. Additionally, it highlights the overrepresentation of clindamycin and doxycycline in MSAI-DASC compared to their actual anaerobic potency. The Anaerobe Antibiotic Index quantifies susceptibility of clinical isolates, but not commensal anaerobes, lacking standard breakpoints. It omits several antibiotics due to absent anaerobic breakpoints. The Anaerobe Antibiotic Index doesn't predict Clostridioides difficile risk, and only early exposure in burn cohorts was evaluated, indicating a potential early protective effect needing further study. Binary classification of antibiotics is inadequate, missing crucial potency gradations. The anti-anaerobic index reveals a 15-fold range in anti-anaerobic activity. Higher anaerobic exposure correlates with increased harm in burn intensive care unit patients. The anti-anaerobic index is a research tool, not a bedside score, and will require updates as new data emerges, aiding evidence-based antimicrobial stewardship.